Welcome, everybody, and thank you for joining us. Today, I'm excited to introduce Dr. Gautam Mehta. Dr. Mehta is a neurosurgeon at the House Institute Neurosurgery Clinic and a clinical scientist at the House Institute Foundation. He was the first graduate of the Joint Neurosurgery Training Program at the NIH and the University of Virginia. There, he gained extensive experience with pituitary tumors, endoscopic surgery, peripheral nerve tumors, and radiosurgery. He then completed additional training in skull-based surgery and neurosurgical oncology at MD Anderson Cancer Center. Dr. Mehta's work has been recognized by awards from the American Brain Tumor Association, the North American Skull-Based Society, the American Association of Immunologists, the National Institutes of Health, and the University of Virginia. He has authored more than 50 peer-reviewed research articles, including 8 publications on VHL, and is on the editorial board of the Journal of Neuro-Oncology. In addition, Dr. Mehta led the ELST subcommittee for the VHL Surveillance Guidelines Task Force. Today, Dr. Mehta will be discussing the differences between hemangioblastomas and other brain tumors. Dr. Mehta, thank you for joining us.
Thanks so much, and thanks for that introduction, Josh. So I'm going to share my PowerPoint here. So again, Josh, thank you, and thanks to Eileen also for inviting me to do this. Both of you have brought up this kind of important topic in VHL and with hemangioblastomas, that it's important to understand what the difference is between hemangioblastomas and other brain tumors. A lot of clinicians are familiar with other kinds of brain tumors because hemangioblastomas, frankly, are quite rare. And so it's important, really, as patients and advocates, to understand where hemangioblastomas fit in this picture and how they're different from other tumors. So this gives you a little bit more ammunition in terms of understanding where a doctor is coming from or other patient advocates may be coming from. So we'll be talking about how hemangioblastomas fit in this brain tumor landscape. Let's see if this is, okay, there we go. So this is important for some of the reasons I mentioned. Most of the, or many of other brain tumors that people think about when they say somebody has a brain tumor are brain cancers. And this is an important distinction that we'll discuss. Hemangioblastomas specifically are quite rare among brain tumors. And hemangioblastomas, for a number of reasons, need unique treatments, which we'll discuss today. And they also require unique research. And these are really important as patients and advocates to understand, because a lot of our research interests and our energies really need to be focused on hemangioblastoma and VHL specific research and treatments. So in this session, I want to review the different kinds of brain tumors and where hemangioblastomas fit in this. I want to kind of to go over some of the lingo that clinicians use to describe brain tumors. And this again gets back to this issue that physicians may be more familiar with some of the other more common types of tumors and not hemangioblastomas. But understanding of what the differences are between hemangioblastomas and these other brain tumors gives you a little bit more of a background for then describing what the issues are to your clinician. And then we'll also review how hemangioblastomas are unique and what we're thinking about from a clinician standpoint when we're treating them. So this is a rough overview. I'm going to cover a lot of information on other kinds of brain tumors, but we'll summarize at the end what the important points are. But really, the two main distinctions in the brain tumor landscape are primary and secondary brain tumors. Primary brain tumors are tumors that actually come from the brain or from its surroundings, and these include hemangioblastomas. The more common category when someone has a brain tumor is a secondary brain tumor, and these are cerebral metastases. These are tumors that come from a cancer elsewhere in the body, where a malignant cell actually breaks off from that tumor and travels through the bloodstream up to the brain and takes seed there. These are, again, more common than primary brain tumors and actually do apply to VHL, although they're in VHL, they're less common, but they can come from renal cell carcinoma or pancreatic tumors. So with those two, out of those two categories, we're going to focus on the primary category, kind of funnel down on that. So primary brain tumors have a couple subcategories as well. And this is an important distinction because when people think about brain tumors, people are often thinking about brain cancers. Hemangioblastomas, as most of you know, are benign brain tumors. Benign brain tumors are often curable. They include hemangioblastomas, and most of them are what's called WHO grade 1. And this is the World Health Organization grading scale for brain tumors in terms of their degree of whether they're benign or malignant. So it's a 4-point scale. Hemangioblastomas are grade 1, which means that they're the most benign subtype or category. And you may see that on a pathology report for after a brain hemangioblastoma surgery. These are not cancers, but they still can be a problem, obviously, due to growth and location. Malignant brain tumors are the other category. These are typically incurable, and they're considered malignant because they're invasive, because they can spread throughout the brain. They're not just a distinct mass, but they actually infiltrate throughout the brain. So to give some perspective of how many patients this actually these apply to, these are actually the numbers from the U.S. Brain Tumor Registry from 2012 to 2016, showing the relative incidence of different tumors. So as you can see, most of the primary brain tumors in the U.S. are non-malignant, so about 70% are in this blue category, so this part of the pie chart. The majority of these are meningiomas, which we'll briefly talk about later, so that's that dark blue. Hemangioblastomas actually fall in this little subsection of or slice of the pie chart. So this is all other non-malignant brain tumors or primary brain tumors. And that slice is 6.2% of all brain tumors. Hemangioblastomas actually make up 1.5% of this overall pie chart. So it gives us a little bit of perspective of how rare or how common hemangioblastomas are. So a lot of clinicians have seen malignant brain tumors, have seen meningiomas, have seen pituitary tumors, but they may not have seen hemangioblastomas. And it's because of this incidence. So just to take this point home, I just want to talk about some of these other kinds of benign brain tumors, which people often think about when they're thinking about benign brain tumors. So meningiomas are the most common. These are the most common kinds of primary brain tumors. These actually come from the linings of the brain. They affect patients with NF2. So you may have heard about them that way. Maria Menounos recently had a meningioma removed, so I know this was in the popular news recently. Pituitary tumors are also pretty common. They're tumors that come from the pituitary gland, and sometimes they can secrete hormones, which makes small tumors act funny. So this can lead to gigantism. Andre the Giant actually had a pituitary tumor that was secreting growth hormone, which led to his size. And vestibular schwannomas are the other pretty common benign brain tumor. And these come from the balance nerve. And Mark Ruffalo actually had a vestibular schwannoma that was treated. Malignant brain tumors get a little bit more of the press and are in the news even more than some of these benign brain tumors. And that's for a couple of reasons. These are brain cancers, and the most common are gliomas, and even among those, most commonly glioblastomas, which are the most aggressive tumors. And these come from the brain itself. And in the news lately, these have affected John McCain, Beau Biden, Ted Kennedy. These tumors they're very aggressive and lead to a median survival. So a survival after diagnosis on average of less than 2 years. So because of the frequency of these tumors and because of how aggressive they are, they do actually get most of the research funding, and most of the research energies are directed towards trying to treat these specific brain tumors. So for example, the National Cancer Institute, which has a $200 million budget in 2017 for brain cancer, most of that went towards glioblastoma research. Similarly, the American Brain Tumor Association had $1 million budget in 2019, and at the bottom of the screen are the different tumor types that this was used towards, and most of these are different kinds of gliomas or malignant brain tumors. So when people talk about doing brain tumor research, a lot of this goes towards these malignant brain tumors, these brain cancers, likely because they're so aggressive and because they're so much more common. So it's important as patients with VHL and as patient advocates that we understand how much of what applies to other brain tumors actually applies to hemangioblastomas. So some of the surgery techniques are similar. What we apply to other brain tumors can apply to hemangioblastomas. There are certain techniques that are very specific to hemangioblastomas, but the outcomes of surgery may be a little different. Radiation therapy and radiosurgery, it's basically the exact same technique. For radiosurgery, for hemangioblastomas, we may just give a slightly different dose for hemangioblastomas versus other kinds of brain tumors. But again, the outcomes may be different for hemangioblastomas. And that's because the cells in hemangioblastoma tumors may respond differently to the radiation therapy. And then lastly, the third therapy for these tumors is medical therapy. And this is really very different between hemangioblastomas and other kinds of brain tumors. And we'll describe some of the reasons for that coming up. One second. So some of the things that make hemangioblastomas unique, probably one of the most important is the location of these tumors. So the location of these any brain tumors really affects what kind of symptoms folks present with, and it also affects how we treat these tumors. So based on location, a tumor may be more or less amenable to surgery or radiation therapy, and it may make surgery more challenging. Some of the locations of these hemangioblastomas are more difficult than in terms of surgery than some of the other kinds of brain tumors, the more common kinds of brain tumors. And I'm sure most of you are well aware of this, but hemangioblastomas tend to affect the base of the brain, so the optic nerve, the pituitary stalk, the brainstem, the cerebellum, and the back of the spinal cord. Hemangioblastomas can also occur in the rest of the brain, the top part of the brain, but it's relatively uncommon. Yeah, another unique aspect of hemangioblastoma is, or hemangioblastomas are that they're associated with cysts. And as you all know, this is very common in VHL and with hemangioblastomas, but it's really not that common with other kinds of brain tumors. There's some kinds of brain tumors that do have cysts associated with them. And sometimes we think about that when we see a patient present with a tumor with a cyst. That may be a hemangioblastoma or maybe this other kind of tumor. But the vast majority of brain tumors don't present with a brain cyst. Cysts are important because they can lead to a rapid progression of symptoms where the hemangioblastoma itself doesn't grow very quickly over time or may not change at all, but the cyst has doubled or tripled in size in 6 month or a year-long interval. The cysts also affect how we do the surgery or how these lesions respond to radiation. And so for surgery, cysts can actually make the surgery a little bit easier because the cysts do a little bit of the dissection for us. So for example, in this spinal cord hemangioblastoma, on the left side, we can see the tumor is bright and white here, and surrounded by this big cyst, which we can see in white on the right side of the screen. This cyst has actually pushed the spinal cord away from the tumor, and it's done a lot of the manipulation. It's done a lot of the dissection of the tumor from the spinal cord or from the nervous tissue. So when we go in, we have to remove the tumor from the nervous tissue that's immediately surrounding it. But then the cyst has done a lot of the rest of the work. So it leads to potentially less trauma to the nervous system. In terms of radiation, that also can be complicated by cysts, which we know that the tumors oftentimes can respond to radiation, but at least with hemangioblastomas, the cysts don't tend to respond as well because the cysts are separate. They're really produced by fluid that's coming from the tumor. So the cyst itself is not going to shrink just because that area is radiated. It's only going to shrink when the tumor is really deactivated and is not producing that fluid, and the fluid gets reabsorbed. Another unique aspect of hemangioblastomas is that they're very vascular, meaning they're made up of blood vessels. Hemangioblastomas are thought to arise from some of the kind of primordial vascular cells, the cells that eventually go on to become blood vessels and blood cells. And this really affects how we do surgery, because these tumors are among the most vascular, the most bloody of all brain tumors that we treat. And if we don't have that knowledge going in at the time of surgery, it can make things quite a challenge. So for tumors that are in these really sensitive locations, usually what we do to minimize the risk to the surrounding nervous tissue when we're dissecting a tumor away from the surrounding brain tissue or spinal cord tissue is we'll start taking out the tumor from the inside. We'll core it out, and then we'll fold the tumor in on itself. And this requires less manipulation of the surrounding nervous tissue. If you have a hemangioblastoma and you try to do this and you start coring it out, these tumors tend to bleed uncontrollably, and it really makes surgery a challenge and unsafe. And so the best way to take these tumors out is to take them out in one piece. So this requires a little bit more manipulation of the nervous tissue around the hemangioblastoma. And that can be a challenge. And if you don't have experience with that, if you don't know that going in, then it makes that difficulty level even higher. The other thing about these tumors being vascular is that they can bleed spontaneously. I know we all know somebody who's had that happen, but this overall is quite rare. The other thing that's important, obviously, in VHL specifically, so aside from hemangioblastomas, is that these tumors are multiple. And so unlike treating a solitary benign brain tumor, removing the entire tumor doesn't lead to a cure. Another tumor can pop up and start growing. So that really needs to change the attitude to how we treat these tumors. So, a surgeon or a clinician who only has familiarity with treating solitary tumors, so tumors that are in complete isolation that just pop up, by a genetic accident later on in life, they may not have familiarity with how to treat these tumors, because for those benign tumors, maybe the treatment is you remove it, you're cured, you're done. We don't have to worry about it anymore. But for hemangioblastomas and VHL, we know that there may be other tumors that are going to grow over time, and we may have to treat those, and we don't want to do unnecessary surgery. We want to limit those the number of total surgeries. And so generally, the surgical principle for hemangioblastomas that's been developed by Russell Lonser and Ed Oldfield was to only treat these tumors if they're symptomatic or they're causing symptoms. So that's very different than how we treat solitary benign tumors or other kinds of brain tumors. The genetics of hemangioblastomas are also unique, and I'm not going to get into the whole VHL HIF pathway, and I'm sure many of you are familiar with this, but the genetics of these hemangioblastomas are very different than the genetics and the biology of other kinds of brain tumors. So even though some drugs that are used to treat brain tumors are used across a variety of different brain tumors, they may not apply to hemangioblastomas because hemangioblastomas are actually a little bit more like renal cell carcinoma than other brain tumors. So it may be that drugs or medical therapy that are applicable to renal cell carcinoma are our best bet for the ones to treat hemangioblastomas as well. Another thing that's in the news a lot lately is immunotherapy as potential therapy for brain tumors, for all kinds of cancers. This is something that may be applicable to renal cell carcinoma, but maybe not as useful for hemangioblastoma. And the reason why is because of how immune therapy works. So the immune system in general basically patrols the body looking for foreign antigens. So basically something that doesn't really belong in your body. It's not from your body. So like a virus, a bacteria, it senses that, and then it primes the rest of the immune system to fight that foreign item that it's seeing in the body. Same thing actually happens in cancer. So in cancer, you have cells that divide rapidly, and then they form these mutations. The mutations actually aren't what the body is programmed to normally make, and they produce these abnormal proteins. And the immune system can patrol and actually sense those abnormal proteins and remove those abnormal cells because it's sensing that abnormal protein based on the mutation. So this is how immunotherapy for cancer works. It's basically accentuating what the body already does, in that it's noticing these mutations in these cancer and then removing these cells, which are abnormal or shouldn't be there. The way that effective immunotherapy works is it really relies on the number of mutations. So cancers that are very rapidly dividing, and certain kind of cancers like metastatic melanoma, certain kinds of lung cancers have a lot of mutations. So we're talking, 400 mutations or more. And these cancers, because they have so many mutations, have more of these abnormal proteins that are expressed. And the body's immune system is more likely to target those cells as being abnormal and not from the body itself, or not normal to the body. There's been a lot of research that's shown that highly mutated cancers respond better to these immunotherapies. With benign tumors, there are really very few mutations. And obviously this is good because these tumors are less aggressive because of that. They grow much slower. And they're not going to metastasize like renal cell carcinoma does. But these benign tumors like hemangioblastomas, because they have less mutations, they're not really great candidates for immunotherapy. At least in the present form, I should say. The other thing that is in the news a lot lately with certain gene editing technologies is gene therapy. And I just wanted to highlight that there's an extra layer of complexity in VHL with gene therapy. In gene therapy, there are some, and again, to preface this, gene therapy has not been very successful for tumors in general, especially brain tumors. But the approach to this for VHL would require two different techniques or approaches. One, we'd need to treat existing tumors with the gene therapy to make them go away, but we'd also need a different kind of gene therapy to try to prevent new tumors from forming. And so these are two very different approaches, and it really takes something that's already very complex and makes it doubly complex. So I think that's just something that we have to think about and temper our expectations for gene therapy with hemangioblastomas. So I know I covered a lot of different things, and I covered a lot of non-VHL stuff. But I just want to kind of hammer home the point that hemangioblastomas are very rare primary brain tumors. They're not cancerous. And because they're rare and because they have a number of unique features, they really require specialized care. And then finally, treatments that are applicable to other brain tumors may not readily apply to hemangioblastomas. And maybe it may be that some treatments for renal cell carcinoma, which have similar biology to hemangioblastomas, may be more appropriate. And then finally, further research really needs to be hemangioblastoma or VHL specific if we're going to find a cure. And I just want to end this by thanking some of my mentors in VHL and with hemangioblastomas. Alex Fortmeyer, who's a neuropathologist at the NIH when I was studying there as a medical student. Russell Lonser, who was at the NIH when I was there as a resident. Ed Oldfield, also at the NIH, who passed away a couple years ago. And Ian McCutcheon, who was at MD Anderson when I was there at fellowship. And then finally, thanks to Josh and Eileen, I couldn't think of two better advocates for your organization for patients with VHL. Thanks.
Dr. Mehta, thank you so much. So we have a few questions from the live audience. Now you touched on the people with VHL having possibly having multiple hemangioblastomas. Does having one make a person more likely to develop more? And is there a difference between the brain and the spine in that context?
Right, so that's a great question. I think right now, I don't think we have specific research that says if you have, so I presume your question is if you have a small number, are you more likely to grow more over time? We don't have direct evidence that says that there are different rates of growth in different people, but anecdotally, I've seen that some folks with VHL tend to have fewer tumors. Primarily if they have very few tumors and they present at an older age, they may be prone to developing fewer over time. But we don't have really good genotype, what's called a genotype phenotype correlations yet on that. And can you remind me the second half of the question?
Is it the same for the brain and the spine?
Yeah, I've definitely seen that sometimes when there's a high number of hemangioblastomas in the cerebellum, that may correspond with a high number in the spinal cord as well. And that may be more related to genetics than anything else.
Here's another question we have from the audience. What are some specific symptoms that people should be looking for that should show when the time has come to pursue treatment for hemangioblastomas and cysts?
So I think most people will, not everybody treats hemangioblastomas differently, but I think the way kind of I learned this and what I feel strongly about is treating these tumors when they become symptomatic. So I think any new symptom should trigger a conversation about treatment. Because what we don't want is for that symptom to become permanent or to get worse, say weakness or numbness. We don't want that to become so bad to the point where this is now a permanent neurological injury. The tumors cause symptoms by pressing on the nerves in the spinal cord, in the brain, by causing pressure. And when they do this, they can injure the nerves so they're not working as well. And this causes some of the symptoms like weakness, numbness, but that may not cause a permanent damage to those nerves. Those nerves may still be intact, may still be getting signals across the nerves. We don't want it to get to the point where now they've thinned out the nerve so much that they're not getting that signal across. Or that then when we go and do surgery, the nerve is so tenuous that it's very easily damaged. The symptoms for hemangioblastomas really vary depending on the location. So for cerebellar tumors, what we're really looking at, and what I've seen mostly, is that people present with headaches, and that those are new, and that's usually due to cyst growth. Another symptom can be balance issues, but that really depends on the type of area of the cerebellum that's affected and how big the cyst is. For the spinal cord, it can be balance, numbness, or weakness. But if any of those symptoms are new, that should trigger a conversation with your doctor about which hemangioblastoma is causing the problem, and then should it be treated.
Thank you. Can you speak a little bit to the expected long-term prognosis for somebody between SRS or radiotherapy like Gamma Knife versus traditional surgery?
So it depends. You know, there have been a number of papers on radiosurgery for hemangioblastomas. We published one of the largest in 2010 in the Journal of Neuro-Oncology, looking at the outcome of radiosurgery for hemangioblastomas. We found that it was effective in controlling growth in about half of these tumors. You know, with radiosurgery, what we're really hoping, and in general, you know, not just for hemangioblastomas, with radiosurgery, we're hoping for these tumors to either stay the same size or shrink. And so it's a little different than surgery where we're actually removing the tumor. With surgery, if something's causing pressure because it's, or causing pressure and then causing symptoms, we can remove the tumor and potentially get those, you know, that neurological function back. With radiosurgery, we're hoping that basically this tumor doesn't get bigger with time. So that approach really dictates what the prognosis is going to be with these therapies, and really dictates who's a good candidate for surgery versus radiosurgery. So if you have a big tumor, something that's causing neurological symptoms, has a big cyst, this would be something that would be really a good candidate for surgery. And prognosis really depends on where it is. I'm sure a lot of you are aware that, you know, brainstem tumors are a little bit more of a challenge than cerebellar tumors. And then spinal cord tumors are a challenge as well. And they, it really depends on where they are in the spinal cord or where they are in the brainstem. Do they present to the surface? There are a lot of different factors that affect prognosis. With radiosurgery, if you have a large symptomatic tumor, I think it's at least in my opinion, I think it's not very likely that you'll have a good prognosis from that treatment. If you have a small asymptomatic tumor, maybe it'll control growth. But the question that we always kept running into was that tumor growing anyway? Or was it going to stop growing? A lot of these hemangioblastomas grow and then they stop growing and then they grow and maybe they stop growing for many years. And so the radiosurgery studies have not been very convincing in that they've really changed what the natural trajectory of these tumors are going to be. So were they already going to be growing? Were they going to stop growing? Has radiosurgery actually affected that? Some of the studies for radiosurgery include some really tiny, like, 1 millimeter tumors. And we didn't know if those were going to be growing anyway. And so it's hard to really extrapolate results. So I think we're not quite there with radiosurgery. Obviously, some people have had so many surgeries, and I understand I wouldn't want to go through another brain surgery after 9 or 10. And then radiosurgery should be in the equation. But right now, if all else is equal, I think evidence still supports surgery.
Can you tell us a little bit about the difference between endolymphatic sac tumors and hemangioblastomas?
So that's a great question. So endolymphatic sac tumors are actually, so they're a whole different kind of tumor. It's just like renal cell cancer, carcinoma is different than hemangioblastoma. They're coming from a different cell type. They occur in a slightly different location. It just happens to be that location is very close to where hemangioblastomas usually come from. But endolymphatic sac tumors actually come from an inner ear structure, and the inner ear is very close to the cerebellum. And actually, the inner ear and the cerebellum they both can control balance a little bit. So in terms of some of the symptoms, you may see some of the same symptoms. Endolymphatic sac tumors are also benign tumors. So they're that World Health Organization grade 1 tumor. They're not cancerous. I think there's been some confusion in the scientific literature about that in the past. The main concern with endolymphatic sac tumors that's different than hemangioblastomas is that they can cause hearing loss. And with VHL, of course, we're not talking about just one tumor. Both hearing apparatus or both inner ears are at risk. And so if you have hearing loss in one ear, and that's something that's very livable, but having hearing loss in both ears is a whole different scenario. And so that's why we do some surveillance for endolymphatic sac tumors. And it's important to have a discussion very early on once one's diagnosed with an endolymphatic sac tumor about whether or not it should be treated. And sometimes for those different than hemangioblastomas, we'll treat them even if they're not symptomatic.
Two more final short questions. Are you aware of any use in the treatment of hemangioblastomas of umbilical cord plasma?
I'm not aware of that. I haven't heard anything about that. I apologize.
And then just one final question. Are you aware of any research that's currently looking into the effects on patients who have had multiple craniotomies for multiple hemangioblastomas?
You know, I don't know if I've seen any specific research about that. You know, there can be a number of different effects, and you know, we published a lot of the surgical outcomes from the NIH, and so this was a lot of work that Russell Lonser and Ed Oldfield had done there, and a lot of the published outcomes were from patients who had multiple craniotomies. I don't think there's any specific research on that in and of itself, but that is a very important consideration. You know, I think there's certain things that are easier and certain things that are more difficult with multiple craniotomies. You know, with multiple craniotomies and with VHL, we often plan our incisions with that, you know, right in the middle, with the idea that there may be another incision coming up or another surgery coming up, so we can use that same incision. So it's important from a planning perspective from that point. Sometimes, at least in my experience, I've seen that there's often a little bit less pain with going through that old scar tissue because the nerves haven't really formed normally through that. It's not the same for everybody. Sometimes the risk of a spinal fluid leak, which is one of the risks after these surgeries, can be a little bit worse after a redo operation or a second operation, just because, you know, the tissues, every time we go in, the tissues become a little bit more scarred down. They're a little bit less natural. It's a little bit harder to close things up in a watertight fashion. The other problem with multiple craniotomies is every time we go in, we're by nature damaging the brain a little bit. And, you know, the cerebellum is very forgiving, and we can, when in removing these tumors, we're able to remove them, and sometimes even when they're very large, you know, injure quite a bit of the cerebellum in that process, and people still may not have any symptoms from that or any balance problems. But there's a point, in depending on where the tumor is located, that can eventually add up and cause problems, and it's just something that we have to bear in mind. I don't think that multiple craniotomies are then a reason to pursue other treatments, but obviously there's a balance.
Dr. Mehta, thank you so much for taking the time to talk to us today, as well as for everything you do for your patients and the VHL community. We're all so very appreciative.
Thanks so much, Josh. I appreciate it. Thanks for having me on.
Thanks. And for everyone watching at home, you can find more great VHL Alliance events by going to vhl.org/together. I hope you'll join us again soon. In the meantime, stay safe.